So today we're going to be talking about psychosocial disability and how the NDIS can help someone with psychosocial disability. We're going to be talking around the eligibility criteria. We're going to be talking about how to gain access for psychosocial disability when you're already on the scheme. We are going to talk about what can be funded, where health lies when it comes to psychosocial disability, and around psychosocial recovery coach, because that can be a bit of a confusing term. So we're going to talk a little bit about that. My name's Alex, and I work at Fighting Chance as a senior support coordinator and recovery coach. And I also work in the access space. I've got a clinical background of occupational therapy, so I have a bit of an understanding, and I've been in this space for some time. Before I start, I just want to acknowledge the traditional custodians of the land on which we meet today and pay my respects to their elders past, present and emerging, and extend my respect to any Aboriginal or Torres Strait Islander.
Oh, it's the same webinar, is it?
Yeah. So what we're going to start with, what is psychosocial disability? I'll also say before I start, if there's any
listen to it until she does
it. If everyone can mute themselves, but also if there are any questions, feel free to put it in the chat. Ali and Susanna are also here from Fighting Chance, and they'll be monitoring the chat. And Ali, or Susanna, if there's anything that comes up throughout that you want to stop me to ask questions, just do that. And then there'll be also time for questions at the end. So I'm going to start today by talking about what is psychosocial disability. So essentially, it's a term that came through the NDIS, and it has been psychosocial disability has come out of the NDIS because they've essentially noticed that with the health system who handle mental health, there's a gap, a big one. And so people who have been through the mental health system, they've had treatment, whether it's medication or psychotherapy or whatever it may be, inpatient or outpatient or a bit of both, there's still significant for someone with a psychosocial disability or for someone with a long-standing mental health condition who have exhausted all of what health can offer. There can still be challenges with employment, social interaction, with sort of day-to-day life, motivation to kind of live independently or be able to live independently. And that's where NDIS have said that this is what a psychosocial disability is, and they've identified this as being something that the NDIA can support with. But they clearly define it as not everyone with a mental health condition has a psychosocial disability. Some people with a mental health condition have, which is many people in the world or in Australia, can see a psychologist, have medication, and they're okay to manage life. But for some people that's not the case. And for those people, then additional support can be accessed through the NDIS, with health still being involved and can still be involved from that treatment perspective, whether that's inpatient or outpatient, but through medication and treatment interventions like CBT or DBT or ECT or whatever it may be. So for the eligibility criteria is still the same as with any disability. So age, residency, and disability is still considered. But when it comes to psychosocial disability, there is a lot more focus on health's responsibility, essentially, and proving that health have exhausted what they can do. And despite what health can do, there's still significant functional impact. So just going through Section 24 of the NDIS Act, or the legislation, is what the access team at the NDIA review, when they look at this. And so just briefly going over this is directly from the Act. So Section 24 1A is that the disability is linked to intellectual, cognitive, neurological, sensory, or physical impairment, and or impairments that are around someone's psychiatric condition, so a psychosocial disability. The impairment is or likely to be permanent. When it comes to proving this, it is not saying that you're never going to get better or your loved one is never going to get better. It's saying at this point in time, health have exhausted what they can. It doesn't mean that you can't have future treatments, but health have exhausted what they can. And despite that, there is still significant functional impairment that requires support. I know it can be quite hard to hear that or see that in a report or letter to say that it is likely to be permanent, but it doesn't mean that there isn't the capacity for you to build that and exit the scheme, or build that and for it not to be permanent and lifelong. But just in this space, it needs to be said. It results in substantially reduced functional capacity. And this is in the 6 domains. So communication, social interaction, learning, mobility, self-care, and self-management. We'll go into a little bit more of what that looks like for someone with a psychosocial disability, and I'll give a few examples in a couple of slides. That the impairment affects the person's capacity for social and economic participation. So it impacts their ability to sort of go out in the community, be a part of the community, but also to participate in work. So they might be able to still do their job, but their psychosocial disability could mean that they have difficulty with that initiation, getting out of bed, time management. Those executive functioning skills are impacted. So they're not able to kind of get there. There might be challenges around engaging socially because it might be extremely overwhelming due to their psychosocial disability. So their economic and social participation is impacted, and that they're likely to require support for a person's lifetime. And so all of these things are assessed. And the reason for understanding this and understanding the Section 24 is that when providing the supporting evidence, we want the letters and reports and everything to address this and answer all of these things. So when they're looking at it, they look at it and go, yep, that's ticked off. Yep, that's ticked off. And then we will give you access. What does so I just want to go over a couple of things that I've said. So like what does permanent impairment mean? So there's a loss of or damage to mental function, which impacts, and it's likely to be permanent. So it's likely to not change. But also that when it comes to, if a report says, or a letter says, so-and-so has this diagnosis, they've undergone these treatments which haven't worked, but they're about to start this treatment. And then it goes on to say it's likely to be lifelong and permanent. They're not going to consider the lifelong and permanent because they've previously said that there's another treatment that's going to be trialed. So the impairment, they're saying, is not going to change or not likely to change, but it doesn't say that it can't change, and doesn't also say that you can't engage in health treatments down the line. You absolutely can. We just don't say that to the NDIA because we don't know that's going to happen, and we don't know what's going to happen in the future. But at this present time, you've exhausted all of what health can offer. And all treatments have been exhausted. If they see that you're about to start a treatment, they're going to say, wait until that treatment has been done and the outcome of that treatment. If that hasn't worked, then we will reconsider. So that's where there's no known and available evidence-based treatments. And what does functional impact of the impairment mean? Another question that I get quite a lot. Clinically, whether it's a GP or a psychiatrist or a social worker or a psychologist, whoever it is, or an occupational therapist, when at university, we are taught to write using medical language. We are not taught to write in the NDIS functional language in that world. So a lot of what is spoken to in a way of that the so-and-so has this symptom, but it's not described functionally. What does that look like day to day? And I'm going to actually stop sharing for a second. I'm going to share a prompt document, which we're going to share after this. And I find it quite helpful in the psychosocial space to explain what I mean in this. So just give me a sec. I am not the best at showing my screen with various things, but I'm going to try. Now I'm going to start sharing again. And so this document I find quite helpful. And so this is prompts for, so it's only prompts, but what it can be used for and what it's quite helpful in showing is these are the 6 domains on the left-hand side. When we're speaking in medical language, we are often used to just labeling the symptoms and stating them. This person has these symptoms. What the NDIA are looking for when it comes to a report or a supporting letter, whether that's from a GP, a psychiatrist, whoever it's from, is they want examples of how it impacts functionally. So when the person's writing that, what is very helpful is that, yes, they can say the symptom, but giving an example of what that looks like day to day is extremely helpful in the NDIS space. When it comes to access, whether it is someone who has already met access and is wanting to add psychosocial disability, or whether it's someone starting fresh in the access journey and wants to go through psychosocial disability, the having supporting evidence is required, and having supporting evidence around the functional impact is needed. So when we're talking about what do they mean by functional impact, this is what they mean. So so with mobility, these are the symptoms that might impact the person's mobility, but here are examples of what that could look like functionally for the individual. And it's what that could look like functionally is what the NDIA want to hear. They don't want to hear the symptoms or a list of symptoms because they look at that and say that's health's responsibility. They want to see how it impacts functionally in these 6 areas. So we will share this document afterwards. And obviously it is just a prompt. And so it's not about copying and pasting this, but it's just a guide to go, when you think, what do they mean by functional impact? This is what they mean. So I'm going to just stop sharing and go back to the PowerPoint. Keep going. So, So this is just, I've just sort of briefly spoken about what each of those domains involve. But a lot of people look at mobility and think that mobility isn't impacted because the person has a psychosocial disability. That's the biggest one that I find people ignore. But it also includes people being isolated because they won't leave the house, or because if there is a symptoms of or side effects from medication that could include high levels of weight gain that then impacts on their ability to move around, that also impacts on their mobility, and it relates to that. So mobility can actually be impacted for a person with psychosocial disability. So I have, I'm going to just make sure. Yeah. So that there, when it talks about functional impact, out of those 6 domains, you don't have to, there doesn't have to be significant functional impact in each of those domains. It just needs to be one or more. But it needs to be significant. So there needs to be quite a fair amount of impact. And so some people say that they're impacted because they feel sort of overwhelmed with life and everything. What we need to decipher is, when it comes to significant, what that looks like for the NDIA, and where they really focus on is that social and economic participation, as well as their independence in life in general. So if one or more, you'll find that a lot of these are intertwined. So if you think about one domain, there is typically more than one that's impacted. But when it comes to what that looks like or how that is significant, if a person is still working full time, they're still able to drive, they've got friends, they engage in the community, they live independently and they manage, but some days are hard, NDIA doesn't see that as significant enough. They want to see impairment in these domains, but that it's impacting them socially and economically. And in that space, that's where they can help. Otherwise, if they will push back fairly strongly onto the health system. And when supports are considered as well, if a person says, and one of these questions will come up is, what do you want out of the NDIS? And if the person says, I want my psychiatrist funded, and I want my psychology weekly funded, and I need help with paying my medications, they're going to say, well, that's not something that NDIS fund. That is still health responsibility. So when it comes to what can NDIS support, and we'll go into this, but it needs to be in line with what NDIA can actually provide. And they don't say that clearly as part of the eligibility criteria, but it really is part of the eligibility criteria. So to be eligible to access the NDIS, a person with a psychosocial disability will have to have that significant impairment. I've just included the Convention of the Rights of People with Disabilities, gave a broad definition that people with disabilities include those who have long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So when it comes to NDIS, you hear them saying, in line with this, you hear them saying that they support people to access support to build their capacity to live an ordinary life. What that looks like is different for everybody. And so, yeah, this is where that is coming from. So if we're looking at someone who has a mental health condition that's been long-standing, so sort of I would say over 1 year is definitely needed, but usually 2 or more years. And the reason I say that is because multiple health treatments need to be trialed, and the outcome needs to be monitored and noted. If And that's going to that takes some time. If you consider you start on one medication and it takes 6 weeks to kick in to see anything, and then adjusting dosage and everything. And if you have to change medication, plus if you do psychology treatment and stuff, that takes some time to get any outcome. So it is at least 1, usually 2 years or more. So say you have a mental health diagnosis, you meet all the age residency requirements. It's been identified that there are significant challenges outside of what health can support with, and that your clinical team have identified, or you've identified, that you feel like you meet the eligibility criteria for psychosocial disability. There's a few things that need to happen. The access process has changed. So I'll just step through what is important to get, or to know that you have or can get, is speak with your health professionals, make sure that they are on board with it. Number 1, on board to write some level of evidence, because you're going to need it. So an evidence in the form of a letter or a report. One of the first thing is there needs to be a clear letter that is in date, so within a 12-month period, ideally less than that, that states your diagnosis or diagnoses, when you were diagnosed, all treatments that you've had, dates of treatment, and ideally the outcome of that, so whether it's worked or not worked. A clear statement. Ideally, we also want them to write a little bit about the impairment, the functional impairment. But a medical professional like a GP may not necessarily go into that, but we can do that in a different format. But we definitely need the diagnosis, when you were diagnosed, all treatment, and a statement that clearly says that there's no further health treatments, and despite all health treatments, there's still significant functional impact listing the domains that it relates to, and that it impacts social and economic participation, and your psychosocial disability. It's fantastic if they use that language, is lifelong and permanent. I just made a note, which I mentioned before, that there can still be future treatments through health. That's absolutely not off the table. But right in that moment, as it stands, there's nothing more that health can do. Number 2, knowing or that you can get or having any reports from psychologists, social workers, OTs. This can be from a neuropsych as well, that talks to the functional impact of the psychosocial disability. Ideally, formatted with the domains, with examples like that prompt sheet that I showed you. And for access, through the new access process, the access request form doesn't need to be completed anymore. How it works is that's done internally now, but what they request is the psychosocial disability form is still filled out and completed and submitted. And so that can be done by a psych or a social worker or a GP or a psychiatrist. They will ask for information in the domains. That's an opportunity for the person filling it out to write a bit about how it impacts functionally. Sharing that prompt sheet with your provider can be really helpful for them to do that properly, and for you to have the information for it to be given and sort of in line with what the NDIA are looking at. If that's not completed, and if it's not completed, and if it is, or if it says just listed symptoms, the NDIA are more likely to push it back on the health system. If there's detailed reports talking about the functional impact, you can kind of leave out the information in the domains and refer to the report, as long as the report's attached as well. So another thing that comes up a lot is the condition fluctuating. There's no problem with the condition fluctuating. With a psychosocial disability, it often is the case. What needs to be kind of differentiated is that the NDIA don't support or don't provide support for any acute episodes. So if it's an acute psychotic episode, they don't provide that support. That's health. And that needs to be, dealt with either outpatient or inpatient through health. What they're looking at is the condition may fluctuate. So through an episode, the person may be absolutely not able to do anything with their self-care or self-management. But when they're not in an episode, they've still got some functional impairment, but they can still do some things. It is okay that it fluctuates, but it needs to be sort of really heavily documented on what it looks like when a person can't function properly, because what ideally we want to see is the NDIA building the person's capacity to be able to manage through the ups and downs. And if we talk to what the person can do when they're really good, the NDIA isn't going to see that there actually is support that needs to be done. And when the person is actually a little bit better, that's when a lot of the intervention can be really beneficial, because when the person goes through, goes down again, that they've got some of the tools that can help bring them back up. So it is okay if it fluctuates, but it does heavily need to be focused on what does that look like in both times, but what does that look like more so when a person is unable to function. The other thing is talking about, if there isn't any supports in place, the risk of the person going downhill. And if these supports aren't in place, what does that look like? What are the risks? And identifying those. That's another really good point to make in the supporting evidence. So some people have met access for and I see people who have come through as defined participants, and that is they were part of a previous Commonwealth or government scheme and they're on the system, and when the NDIS rolled out, they just came over. So, and the previous systems didn't really identify, like health or mental health really handled the and some community, but really handled the psychosocial space. So a lot of people who came over as defined participants, their intellectual disability, for example, or their autism was recognized, but their mental health condition or psychosocial disability was not. So some people come to me and it might be that we identified that it is really important that they go through access for psychosocial disability, because we're identifying, or the therapists have identifying that the supports that are needed because of their psychosocial disability. And when we look at legislation, Section 34, reasonable and necessary, an NDIS support can't be put in a person's plan or used as part of a person's plan unless it relates to the disability they've met access for. So if we're finding that they require support for something and it's due to their psychosocial disability, that person can't access that support unless it is they've met access for that. So going back through that process, there's no problem to do that. It is similar, but a slightly bit different. So still need the evidence that we just spoke about that you need for access if you're just starting on the journey. But so still need the diagnosis, treatment, and permanency. Still ideally need OT or psych or neuropsych or someone speaking to the functional impairment. The psychosocial form still needs to be completed, but once that's completed, what is also completed is a change of situation form. And that change of situation form can identify that there has been this change, that it needs to be, the disability needs to be added. Here is the evidence, and further supports need to be provided due to this diagnosis. So that's then submitted to the NDIA and be considered. If you have, if you say have someone who is can't, like that you've identified that they are wanting to transition into a home and living option, for example, and they the OT has done a home and living report, but it heavily focuses on the psychosocial disability, but they've not met access for it. What I recommend is that, because it's two different areas, it's two different teams that consider this, and they've got different timeframes. They're at, got different caseloads and everything. What I would consider is doing it in two parts. First, do this and get access, get it listed as psychosocial disability, as listed as an access met diagnosis. After that, then you can submit the home and living request, so the home and living form, the change of situation for that, the OT report for home and living and everything. All of that can then be submitted as well. But because it's all heavily focused on psychosocial disability, you want the home and living team to look on the system and see access met for psychosocial disability. If that is not there, and all the evidence is pointing to the psychosocial disability, they're not actually going to consider it, and they're going to knock it back, because they're going to say, well, all of this is pointing to psychosocial disability. The person hasn't actually met access for it. So meeting access for psychosocial disability and having that listed is number one. And then if there is, supports that are required that are big, like home and living, or big, not necessarily assistive technology would be needed in the psychosocial space, but if it is, it's mainly home and living that I see. So if that is the case, because that's a separate team, if it's just an increase in core and an increase in capacity building, that can all be done at the same time through the change of situation process. Yes, it's two different teams, but an LAC or a planner has, and communicate directly. So can the home and living team, but I find it gets a bit, goes a bit pear-shaped if it's not separated like that. So that can be done as part of the change of situation, to say this needs to be listed and these are the additional supports that are required. What can be funded? So what can be funded when access for psychosocial disability is met? This is really important to understand, because it helps to understand to know whether it's worth going down the path. So for someone with psychosocial disability, a big one that gets asked is, can psychology be funded? Yes, it can, is the short answer. There can be a lot of knockback, like pushback on health in this, because they're like, oh, what about the mental health care plan and everything? So psychology can be funded, but not in a treatment format. So what's considered treatment in NDIS world is weekly appointments. So it won't be it will never be funded as weekly. And it's ideally, you can kind of use your funding semi-flexibly to sort of use it for weekly funding, but I would highly recommend not doing that, because you're kind of taking from one support to pay for another support. But also, if you're having weekly sessions, it is really leaning into that treatment space. What the NDIA want to see and what they fund is psychology in a capacity building space. And so say the person is going to a psychologist to work on social skills or emotional regulation skills, for example. They want to be getting those strategies from the psychologist and then using their support workers or informal supports or community supports, whether it be groups or work or whatever it is, to practice those strategies and skills. If they need a little bit more support, having a support worker to help them to implement those skills, or having social programs, day programs and stuff to help implement those skills, and then going back to the psychologist with what's working and what's not working. That then takes like a good 2 to 3 weeks every time you go there and get some strategies to actually really try out a strategy. And that's what the NDIA mean by capacity building. They're not funding any CBT or DBT or any of those TMS or any of those ECT or anything treatment related. A psychologist can work in a CBT model or DBT model with you. The NDIA aren't going to necessarily have all the notes. They're actually not going to have the notes of the person who is like the professional notes of the psychologist. But the psychologist will need to provide an end of plan summary report, as does all clinicians. And it needs to look at the person's NDIS goals, the clinical goals that relate to the NDIS goals, what's been working, and what are the next steps in the therapy space. So it will come out if there has been sort of a level of treatment or a treatment level of support. The other thing that's important is that the frequency of therapy, if it's weekly, and the person is using it in that capacity, they can start to become quite reliant on that support, and that can be quite unhealthy, especially when the NDIS aren't likely to continue to fund at that level. So it is best to utilize the funding flexibly, yes, but within the framework that the NDIS work. So psychology definitely can be funded. When you come to home and living supports, supports in the home can be funded for psychosocial disability, so support workers, whether that's in a home and living space, as in a SIL or like ILO option, or whether it is within the home environment. Or whether it's in the community. Support workers can be funded in the home and in the community to help with day-to-day things. And also to implement therapy in the home and living space as well. Another question is what can be funded when it comes to SDA, so specialist disability accommodation, which mainly focuses on physical, as it's looking at the bricks and mortar. However, in a psychosocial capacity, SDA can be funded. Typically, we see SDA funded when it comes to in the robust area, and that's robust is when the home is made more robustly. So there's thicker windows if a person is engaging in a lot of behaviors of concern, smashing things and everything. So walls and things can be sort of more reinforced and stuff. So that's what we sort of see in that space. When it comes to other therapies, neuropsych, occupational therapy, totally fine. Social skills groups, day programs, all of those things can be funded and related back to a person's psychosocial disability. When we look at equipment, it tends to be, there's not a whole lot that is funded in the psychosocial space. A lot of people want to get the emotional regulation stuff funded. That's a bit of on the side of caution. Make sure you have a recommendation letter from the OT or psychologist and make sure it's got prior approval. The other thing that is funded under there can be the short-term accommodation, so respite. So that can also be funded in the NDIS space. So there is a fair amount that can be funded under psychosocial disability. It is individualized to the person and it depends on the functional impairment. The health system still plays a role with anything medical. And then when it comes to things like so some people say that, oh, can I get float therapy or hydrotherapy or physiotherapy or massage funded through the NDIS for psychosocial disability because it helps relax me? that's a bit tricky to get funded. I can see where that works, and how beneficial that can be. But again, I would say definitely request prior approval. Even though you have flexibility within your budget, it still needs to be considered within the guidelines, and it needs to be, it's better to have that prior approval than you have to repay out of your own pocket.
Alex, can I just interrupt with a quick question that came through the chat? So Cara has asked, for the going back to access for psychosocial disability, does the psychosocial disability form need to prioritize a specific diagnosis? So she's given some examples of schizophrenia, bipolar disorder.
Yes. So it will ask what mental health condition has been diagnosed, and that will need to be listed, the actual mental health condition and when it was diagnosed. Some people get, like, it might be unspecified psychotic disorder. That's still considered fine. But typically it definitely there needs to be a diagnosis, and the year of diagnosis needs to be in that form. We will share, as part of this, we'll share the psychosocial disability form so you can see what it looks like and everything. And if there are any questions when you look at it or going through it, you can definitely flick it through to me through the Fighting Chance website. I'm happy to answer any of the questions. But yes, a specific question for what mental health diagnosis, because a psychosocial disability doesn't exist without starting with a mental health diagnosis.
Thank you.
That's okay. So just going through what the health system is responsible for. So anything acute. The other thing that's really important is if a person has access for psychosocial disability, they have support for psychosocial disability, and they get admitted to hospital for an acute. NDIS supports are not to go to the hospital. In my role, there's a little bit of discretion there with it, and you can kind of justify some support socially. But when it comes to self-care, when it comes to any therapies, when it comes to all of that, is then considered a duplication when they're in hospital. So none of that can occur. But the only thing that I would say you can discuss with, whether it's the plan manager, the LAC, your support coordinator, whoever it is, you can discuss social support, because the hospital system do not provide it. So it is not a duplication, but they are to provide therapy, and they're to provide all of personal care support, the nursing staff are. But what you find is if a person presents to hospital and they're like, I'm with the NDIS and here's my NDIS support worker, the health system are like, cool bananas, I'm going to step back and not do anything. But in terms of the personal care and stuff like that, that is not their role. Their role is to actually do that, and the support worker isn't to be there. If they're coming to help the person socially and take them out for an hour, that's totally fine. Clinical outpatient and continuing care, even in the hospital, when it comes to mental health care, that's all health. That's all health responsibility. That's funded through Medicare or private health or yourself. Unfortunately, NDIS don't fund that. Clinical rehab or recovery for mental health. So any sort of rehab centers and stuff, again, not funded. Any of the sort of KIMS or like child mental health stuff, all through health. Any residential services, all through health. So help with so when it comes to, there's a number of people who have a mental health condition, they're on medication, the medication gives them diabetes. That is through health. However, if you find that they're, due to the diabetes, due to the mental health condition, due to the side effects of the medication, it is impacting socially and economically and in all of those domains, there can be some support in that capacity, but it would look like skill building support. It would look like there are support in the home or in the community with support workers, it would look like transport support. It would look like support with meal preparation, things like that. It wouldn't involve anything that included injections, infusions, medications, or anything like that. That's all through health. But if the person required support to go to an appointment, to have their depot or something like that, NDIS could fund that. So what is the NDIS responsible for? I just went through that slightly, but they're essentially responsible for skill development, so capacity building supports. So anything in the self-care, self-management, learning, mobility, communication, social interaction domains. So that could be in the self-management. An example here is managing money. So that can be either done through a therapist or an occupational therapist helping to build the skills, and a support worker helping to implement that. It can be done through group programs specifically for financial, like building financial and budgeting skills. We know, and it's clearly documented through years of research, that mental health conditions, like if I give the example of schizophrenia, it's probably the easiest example. Schizophrenia has, as part of schizophrenia, it has positive symptoms, negative symptoms, and cognitive impairment. There's a debate on the cognitive impairment part, but it is very well documented and researched that there is cognitive impairment with someone who has schizophrenia. Every time a person with schizophrenia has a acute psychotic episode, their brain is damaged. Long-term mental health conditions damage the person's cognitive function for various reasons. It changes the brain. So positive symptoms for schizophrenia are things like hallucinations and delusions. They are typically managed through health, through medication, and through psychology, or through different treatments. Negative symptoms of schizophrenia is typically not addressed through health and more addressed through NDIS. That's your lack of skills, or your loss of skills, your loss of functioning. So that can impact your self-care. So you might be able to shower yourself, but you have difficulty getting up and getting into the shower. You have absolutely no motivation. You have absolutely that task initiation, that planning, that time management, all of that's impacting your ability to do the personal care. Your lack of sort of this sort of, I can't care about that. I'm so overwhelmed by how I feel that I just can't get out of bed. And so I require support. Those negative symptoms, the impact on that is typically lost when it comes to the health system. So for a person with schizophrenia, a lot of the NDIS supports focus on the negative symptoms as well as the cognitive impairment. So that's the executive functioning skills, which is obviously a bigger umbrella, but the planning, the problem solving, the ability to kind of those thinking skills, that working memory, even short-term and long-term memory is impacted when someone has a long-term mental health condition. So that's where the skill development can come in. And it could be that it's about improving the capacity, or it could be about maintaining it, and helping to kind of not while the person is at this level, we want to keep that person tracking along. We want to give them, build the skills to the degree that they're able to, so that they can have that independence, can help with their confidence, their self-worth, their ability to kind of participate and engage in the world. All of those things can be helped through NDIS. Social skills development, absolutely through NDIS. Social and recreation support, absolutely through NDIS. That can be one-on-one or in a group. Help finding somewhere to live, and manage the kind of self-management that is needed around living independently and stuff. That can be through NDIS. That can be through support workers and all social work that can potentially come through a person's NDIS plan. Allied health professionals, but it's definitely looking at how the person's functionally impaired, not the person's, not treatment. And then you can have what's called a recovery coach. You can also have support coordination, and as well as help with transitions into a new life stage, help with employment. All of those things can be funded through NDIS. So just going on to what is a psychosocial recovery coach. So it's someone who is trained. It is a person who's a support coordinator can't automatically be a psychosocial recovery coach. Psychosocial recovery coach typically has a clinical background or lived experience, as in they have lived themselves with a mental health condition, or they have a loved one and have supported a loved one. They typically, on top of that, have support coordination or case management experience. The focus is really on a person-centered, well, it should always be person-centered. It's a strengths-based model, and it's a recovery-focused model, and it's a really individualized, individual-led process working with the person. So it's helping to coach the individual on identifying how the supports around them are helping, where the gaps are, supporting them to build their skills, work on their goals, have a bit of autonomy in that decision making, but also in that planning and supporting them to be able to do all of that management day to day and managing their own recovery. It is also really important that they have close contact with health. So you're working really collaboratively within that space, and have a good knowledge of the health system so that you can really understand the responsibility, because health are always going to try and push back on NDIS and vice versa. If the psychosocial recovery coach has a really clear idea of both, then they're able to kind of advocate and push back in various ways, and also educate and translate different things to the individual so it can empower them to have the voice to go, no, actually, this is something that I need to go to this person for, and this is how I support this person. Having really good boundaries is really important as a psychosocial recovery coach, working with people who have long-term mental health conditions, who are quite isolated from society and stuff. It can be really, attachment can be a really big thing. And so managing that with firm boundaries, as well as working with people who have diagnoses like borderline personality disorder. This can be something that can be challenged a lot, is the boundaries, and firm boundaries, good modeling. All of these need to be set really in place from the beginning. So a recovery coach needs to have really good training and understanding in that space. They do work similarly to a support coordinator when it comes to NDIS supports, but it really is working with the person who is motivated, who is at that next stage of their recovery where they're able to take a lot on themselves. Can you have a support coordinator instead when you have a psychosocial disability? Absolutely. So a support coordinator is usually involved when there needs to be a little bit more of the support coordinator doing a bit of that management of funded supports, as well as combining or collaborating with the informal community and mainstream supports, and the person has a little bit less capacity. And so that's really important. But the support coordinator really works within that NDIS framework. Their primary role is to work collaboratively with the participant. So it's really important that whether you have a support coordinator or a recovery coach, they're working with the participant, they're working together and working from a person-centered active support model. So you're working, it doesn't matter what you think is best. It is working with where the person is at, understanding where the person is at, understanding that the person is needing this level of support. This is what the person wants to prioritize. So this is where we need to look, but this is what the person's capacity is. And then going, okay, well, how do we build on that? So for example, I'm going to make this phone call this time. Next time I'm going to make the phone call with you. The time after, I'm going to make the phone call, but you're going to speak. The time after, you're going to make the phone call. So building the capacity in that way, a support coordinator should always be doing that, as should a recovery coach, but it typically is funded more so when the person has a little bit less capacity to be involved and needing a little bit more support with managing day-to-day stuff around their NDIS plan. But you can be funded for both psychosocial recovery coach and support coordination in your plan. So just in summary, while both play roles in supporting the individuals with psychosocial disability, the psychosocial recovery coach really focuses on the mental health recovery and the goals, and the support coordinators really focus on that coordinating and facilitating access to NDIS funded support. So it's a little bit different, but it's, it just depends on the individual where they're at. But you can be given funding for one or the other, or neither, or both. So that is the end of the presentation. There's a few minutes left for questions. Does anyone have any questions, or is there any questions in the chat, Ali?
We don't have any questions in the chat for now, so feel free to pop questions in if you have them, or maybe just jump off mute and ask them whatever you feel more comfortable with.
And I may not be able to answer, but if I don't know the answer, I'll find it and I'll come back to you with it. Thank you, everyone. It doesn't seem like that there's any questions. If any come up, on the NDIS, on the Fighting Chance website, there's an inquiries part where you can send an email with a question. Is that right, Ali? Like you can do a form. I think Ali might be.
Yeah, sorry. Yeah, we just had a quick question in the chat about circulating the slides, which we will absolutely do along with the recording of the session later.
And some additional resources for you guys.
But yes, feel free to pop over to the Fighting Chance website and submit any questions you've got there.
Yeah. Thank you everyone for listening today, and I'm going to stop recording now, and